All right, guys. So here we are, the last part of the PMHNP review course, the crash course that we have it for you. And this one's going to be short and sweet. This one's going to be the point. More about theories, more about nursing terminology, laws, and things like that that you need to know, right? So this part people tend to miss a lot because this is not something that we see in nursing school. Nevertheless, it is important. So let's get to it and get things down to the point. Again, I want you to make sure that you stop and copy, making your own notes to ensure that you have the most chance to pass your PMHNP board certification on the first try. So let's get to it. This is the part 5. All right, so this is the roadmap. As usual, we'll be covering here nursing practice terminologies, uh, ethical principles, patient's rights, screening, brief intervention, referral treatment, which I already covered, but I put a little bit extra into this here. We'll talk about patient advocacy, just culture of justice, right? Just culture of care, recovery model, the 4 components of health policy, case management, law cases and psychiatry is huge, Piaget, and a little bit of Erickson. Then again, I'm not going to cover all the Piaget or not all the stages of Erickson. I'm only covering the things that are most likely to be on your test. So let's get to it. All right, so let's start by using some of the nurse terminologies or practice terminologies that we often see in nursing. You need to know really, really well the difference between scope of practice and the standard of practice. Okay, so the scope of the practice is determined by the state. The state determines the the scope of practice. There's the state legislative statutes, which is the board, the state board of nursing, right? So each state has its own way of delegating what we can and cannot do. Texas is different than Maryland, so forth, right? So Florida, you may have to have someone co-sign your notes, while in Maryland we don't. So we can practice independently in Maryland, which may not be the case in Florida, for example. The scope of practice defines the MP roles and actions. Okay. And due to outdated state regulations, it varies widely from state to state. So it's not the same on each state. So its scope of practice is determined by the state. The scope of practice defines the roles of what a PMHNP can and cannot do. Okay. Now, when you're talking about the standard, this is nationwide. Okay. What are the standards? So think of the standard as above the scope. The standard is pretty broad, is nationwide, is determined by the ANA. Okay. So basically here, it is basically the quality of care. It's broader. Okay. It's broad as the quality of care. This was a PMH can and cannot do as far as this broader practice, for example, of the quality care. It means that it provides a mean to evaluate the nature of care that's delivered. So you can use this to judge in the court of law, for example. So if a nurse goes to a court of law, so they'll look at the standard of practice to decide whether the nurse did act according to the standard or didn't. Okay, so it's a way to judge the quality of care. That's the standard. The scope determined by the state, determined by the state board of nursing. Do not get this confused because likely will be a question that will intertwine these statements. Always understand the question is only right if the complete statement is correct. Okay. Now, how about confidentiality, right? So confidentiality have The client, the patient, has the right to expect that the information provided to the healthcare provider will always remain private, needs to know, right? So the consent is required before any release of information. Now, since we're talking about consent, I want to just open a second here to make a parenthesis here and kind of emphasize something. If you are dealing with a patient that has a psychiatric condition and a substance abuse condition, you need two consents. You cannot just get one consent and think, okay, I got one consent. No, you need two because that's two different uh, realms of conditions that we deal with. But because of the privacy issues, we need two consents. Okay, two consents in that case. Now, disclosure in patient information to the pharmacy without informed consent constitute a breach of confidentiality. And this is so weird, right? Because in practice, we don't see this happening, right? We just consent and send the order to the pharmacy. But the reality here is to protect the patient. For example, what if someone that works in a pharmacy knows the patient? Or what if the patient, you know, whatever case may be, but in order to disclose any information to another institution, right? If you work on this hospital A, but the patient wants the pharmacy on hospital B to have it, so you need to get a disclosure, a consent, informed consent before you send to the pharmacy, right? If it belongs to another institution, right? So that is you need the informed consent before you send it to a pharmacy. Please make sure because this is very weird, but it often comes back in tests. It's just the differentiates the gray area here is pretty dark. So, what are the exceptions in which confidentiality or privacy can be broken, right? So, when the benefit of releasing the information outweighs the risk, this is so important. If someone is passed out, does the person need to give you consent? No, no, no. So, in that case, you don't need the consent because the information that needs to be released to take care of the person outweighs the confidentiality dilemma here, right? When someone has intent to harm oneself or others, you can break the confidentiality. So here is the case in which I want to open another parenthesis here. So before, if you're dealing with someone that has suicidal ideation, homicidal ideation, or whatever the case, before you meet with the patient, you need to let them know about the consent. When you let them know about the consent, you need to let them know that what are what are the exceptions to confidentiality, and then you have to go through each one of those steps. For example, child abuse is an exception to confidentiality. Um, Intent to harm self or others is an exception to confidentiality. That's the duty to warn, Toroff principle. However, you need to make sure where you work in order to report. You can always report to the police. That's not a problem. Or you can always contact the state nursing of state nurse board of nursing to see what's the right answer before you go straight to reporting. Okay, but you need to get the exception of confidentiality taken care of, so that way the client, the patient, is not caught off guard and when someone says, hey, I have a suicidal intention and I wanted to do it now. Okay, so when the court orders, you need to release the information. So summers, or perjury. Because I'm gonna highlight here perjury. You need to know what perjury is. So perjury is that when you go to the court, you're lying under the oath. That's a perjury. So know this terminology. Another example is disclosure to attorney involved in litigations. In disclosure to attorney, if an attorney is involved in a litigation, he needs to know the the documentation, right? Insurance company, how could they pay for, right? If the patient used if the patient used the insurance and the insurance wants to know the information about the patient because they need to pay for it. That's fair, right? Or when it's mandated, reported by uh, by the state, like conditions that are mandated reporting, you need to you need to disclosure. Although I cannot think of any mandated conditions that are psychiatric per se, I could be mistaken, but I don't remember any. But a medical condition, there are several, and that is a mandated report. You need to report to the state, right? Another thing is here, when meeting a patient for the first time, it is crucial to explain the exception to confidentiality, such as intent to harm, right? Because we went over this again, you need to disclosure the exception. So in this slide, you need to know what's confidentiality, right? You need to know what's informed consent. You need to know when is the what are the exceptions to confidentiality. Okay, so it's very important. In the previous slides, we talked about the scope of practice and the standard of practice. The scope is the state, standard is the ANA. A standard is the quality, and the scope is determined by the state nursing board of nursing. Okay, okay. So informed consent. Okay, is what is informed consent? Is a communication process between the provider and the patient that leads to an agreement on the course of treatment, right? For example, remember, examples are important. A patient with dementia who can articulate the benefit and risks of the giving can may give consent. So here are the things. How do you know when the patient can give consent? Well, if the patient can articulate the risk and benefit, then they can give consent. Now, another example, a patient with schizophrenia and current psychosis, can he give consent? No, informed consent cannot be given because the patient is in psychotic uh, state right now, is not fully aware of the options, so that patient cannot give informed consent. Now, are you able to forcefully prescribe medication for a schizophrenic patient with psychosis? No. Okay. So, what is your priority action here? So, your priority action is to assess for involuntary treatment for safety. Okay. So, here, if you can, if someone is having psychosis and schizophrenia, now you can admit the patient involuntary if the patient is at risk of hurting himself or herself, even if it's temporary. So your action in this case is not to give forceful medication, but to assess for involuntary treatment for safety. Ethical principles, super high yield. And I just highlighted few here. Again, we're not going through all of them, but justice, right? It's a committing to fairness, being fair in all aspects of patient care, justice, right? Example, excluding an individual from a medication trial. What kind of principle of dilemma is being ethical dilemma is being affected? That's justice. If you're excluding an individual from a medication trial solely based on the financial status, constitutes a breach of justice. Pay attention on the example. So that's a breach of justice. Okay, when you prevent someone from participating on a medical treatment or medical medication trial just because they don't have the means to it, that is a breach of justice. Okay, the ethical principle that's being breached is justice. How about non maleficence? So that is doing no harm. Non maleficence is doing no harm. Example, discontinuing a medication that may be harmful to the patient will represent an act of a non-maleficence. So you are preventing a patient from, from the side effect because the medication is not benefiting the patient. So example, if you have a patient that is taking trazodone, so trazodone is known or can have a side effect of a priapism, so having an erection that lasts longer, out of nowhere, right? In males. So if the patient has this side effect and you know of, or is at risk added, you can discontinue trazodone. That's a good example. You should know. Discontinue trazodone, and this is under the ethical principle of non-maleficence, doing no harm. Okay. Another example here is when you refraining from providing stimulant to a patient who has a history of stimulant abuse, right? Because the patient has a history of stimulant abuse, you want to do no harm. So that's another good example of a non-maleficence. Okay, imminent dangers. So when the patient has imminent dangers, you are the principle and ethical principle is non-maleficence. Okay, how about beneficence? So this is the opposed of non-maleficence. So this is doing good. Okay, encourage your well-being, performing good deeds, for example. Example of that would be prescribing a antidepressant to a patient suffering from depression. Exemplify beneficence. Okay. How about fidelity? Comes from the word fidel, from the Latin, right? From fidelity. And fidelity means maintain a faithful and loyal, characterized by a promise keeping, integrity, and honesty. Example of fidelity is fulfilling the patient's expectations, um, legitimate expectations of role is a role of a role of fidelity, such as being respectful. I'm gonna highlight here respectful falls under fidelity. Respectful falls under fidelity, competent, professional, and demonstrates principle of fidelity. In fact, you should highlight the respectful, competent, and being professional. These all falls under fidelity because if you get a question that asks about competency, you can get all whacked by saying this is beneficence because it shows doing good, right? You can make up answers. So once you highlight respectful, competence, and professionalism falls under fidelity. Other ethical principle here is veracity, so is upholding the truth, telling the truth, right? And autonomy. Autonomy here is the right to self-governance, is the allowing the patient to decide treatment A versus treatment B, pertaining to the patient, uh, permitting the patient to have authority to accept or reject a life-sustaining treatment. Okay. Okay, what are the patient's rights? Patients have three main rights. I really could have a lot more, but in summary here, has the right to the least restrictive environment. Patient has the right to the least restrictive environment. And what I mean by this is if you can have someone do the treatment on outpatient, why to admit the patients? If you know if the same treatment and the same benefit can be done on outpatient, it's the least restrictive compared to inpatient. Patient has the right to informed consent. We went over informed consent, right? In order to have informed consent, the patient must rationalize, must be able to tell the between the risks and benefit and the options that are given to the patient. And patients have the right to confidentiality. We just saw the confidentiality. It's is a huge in our days, and confidentiality also we talked about the exception of confidentiality. Well, let's do a checking on learning. Yeah, the patient's right, I guess. A new female patient has been diagnosed with bipolar disorder. The psychiatric mental health nurse practitioner, the PMHNP, and the patient have mutual agreed to initiate the treatment for lithium with lithium. The PMHNP has discussed the potential benefit and risks associated with lithium therapy with the patient. Okay. Following this discussion, the PMHNP has electronically sent the prescription to the pharmacy. In this scenario, which patient rights may have been violated? It was A, beneficence. It was B, informed consent. Was it C, non-maleficence? Or is it D, confidentiality? Okay, pause the video, take a quick look on this question, and I hope you didn't get this confused. It was on purpose to confuse you, and but let's see what you got. If you answer confidentiality is the right terminology, right? Because the ethical principle that may have been violated, right? It was confidentiality. The patient has the right to confidentiality, right? So let's go back here. So patient has the right to confidentiality. Patient has the right um, to inform consent, right? And in this case specifically, no informed consent was given to the pharmacy. So what was the breach? The patient's right was breached here in this scenario. The patient right, the right was the breach of confidentiality. Why? So informed consent is there as a distraction, right? Because informed consent here is what was not given to the pharmacy, but what was breached. So it's different question, right? What was breached? It was the confidentiality. Okay. So informed consent is a very strong answer, but it's a distraction here. Okay. Because it asks what was breached? What patient right was breached? It was the confidentiality. Remember, sending the information to the pharmacy, you need informed consent. And if in this case it didn't say the informed consent was given, the provider gave the order to the pharmacy without informed consent. Okay, kind of muddy, I get it, but okay. So another checking on learning here. The psychiatric mental health nurse practitioner is requested they request to collaborate. Collaborate is always a key word with the local inpatient psychiatric facility to provide professional development for the nursing staff. After initial discussion with the administrator to identify the specific issues necessitating consultation, the PMHNP next steps should be to form an interdisciplinary teaching team, establish outcome measure, promote educational program, or survey to assess the staff education requirement. Not necessarily a patient right questions, but the question is still valid and very good. So, after the initial discussion with the administration to identify the specific issue necessitating a consultation, the PMHNP next action should be to form an interdisciplinary teaching team, establish outcome measurement, promote the educational program, or survey to assess the staff education's requirement, right? So this one, even if you didn't know what the question is asking, right, you should always do an assessment first. Option D, you are assessing to evaluate, to collect the information to evaluate the staff education's requirement. Okay? All right. Again, we've seen SBIRT, and I think I'm pretty sure that you will get this question right. So the patient SBIRT screening brief intervention referred treatment is the patient treats treats the patients with health disorder or co-occurring substance use disorder, right? SBIRT stands for screening. The B is for brief intervention. The R, intervention, brief intervention. Then you have the referral to treatment, and then the treatment options and support, right? So instruments that are used in a SBIRT, we said is the cage questionnaire, is a 4-point scale. Two or more indicates a drug or alcohol. If it's just the cage, it can be the cage M, adapted for other drugs, right? So cage, the regular cage for alcohol is only there are only four questions, but two or more indicate the need for more assessment for alcohol use disorder. For the SBIRT, you are going to use the audit score to determine the appropriate intervention according to the SBIRT protocol. So basically, you did an intervention, you did the audit score, and you see if the audit score has improved after the intervention. You can also use the drug abuse screening test or DAST, which is suitable for youth, adults, and really adults as well. Now, as we move on to patient advocacy, right? A nurse ensures that the patient's autonomy and self determinations are honored. So that's part of advocacy. When you are advocating for autonomy of the patient and self determinations are honored, that's part of advocacy. It's part of your role. Nurse advocates prioritize the patient's best interests. When you look at the patient's best interests, you're practicing advocacy, okay, while honoring the family roles and perspective. So here an example: if you have a teenager that comes in and tells you that she is bisexual or homosexual or whatever she tells you, you are obligated to keep that confidentiality, right? Because you are attending for the patient, the minor, right? Best interest, while you still want to honor the family roles and perspectives. But at this point, you are connecting with a teenager, which is your primary client, and the family is the payer, for example. But you still want to protect the client that you're talking to. Now, this is huge. Patient advocacy has to do with stigma reduction in healthcare, in mental health illness. So, if you hear advocacy, you are to think of stigma reduction associated with mental health illness. To reduce that is the role of advocacy through comprehensive psychiatric education. So, education in itself, psychiatric education, it's a role in the advocacy that we do is to educate and also to decrease the stigma in mental health, okay, by providing psychiatric education. Very, very important. Write this down, guys. When deciding on a psychiatric educational method, choose the options that allows for reaching a broader audience, such as radio, right? So, for example, um, questions that I may present, such as one is doing a journal, complete a journal article. Now you want to reach as many as possible. Um, want to maintain, you want to reach as many as possible people. How would you do that? Would you put this in a supermarket? Would you put this in the high school billboard? Would you use the radio or TV or publish the document? So it really depends which one of the option would reach most people and would do better for the research to be disseminated. When this research needs to be disseminated, you need to pick the option that reaches most people. Okay. Now, here is another very important point. When you are educating the patient's community, right, versus the family, okay, options that may present as in you are educating patients from Africa, okay, let's say, for example, and you have noticed that the community has specific ways of doing things, and they give you the choice: a, how would you, let's say the patient has schizophrenia and it's from Africa, okay, just giving you an example here. And if the patient and the question says, okay, and you have noticed this community from Africa have a tendency not to believe in mental health, what would be the next priority action, right? So here the question is asking about the diagnosis and a specific community. So you want to pick the choice of community over a specific family or patient teaching. Okay, I hope that makes sense because the the key of the question here is that you want to reach the broader audience. Okay, and you're doing so by reaching the community rather than just specifically teaching that one patient. Okay, and when you are doing teaching for the patient, you want to be very specific to the patient. Now, if you are doing teaching for a group of many different ethnicities or race or what have you, you want to be ethno specific. So you want to be broader. If you're doing a teaching for a Brazilian community, then you want to be specific to that community. If you have five different countries and different populations, so you want to be more broader on your teaching. Okay, what is the just culture of care? So, in just culture of care, individuals are committed to continuing learning, and this culture of care is designed for system safety while maintaining behavioral choices, while managing behavioral choices, right? So, example here, should a nurse commit a medication error, the immediate action would be what? So, would be to assess the patient rather than uh, finding out that your colleague made a medication error and let me go directly to my supervisor and report the person. So your action is safety, is always ensuring the safety first of the priority of the patient. So prioritize patient safety by addressing it first rather than reporting a coworker. Okay, so that's just culture of care. So it's looking specifically at the system and reframing refraining from assigning blames or blaming others, and you looking at the system and seeing what the system has, why this did this problem happen. Was it the system at faulty, or it was the blunt not following the policy? That would be more of a person error than the system. So the just culture of care is looking for the system and trying to improve it in the system rather than blaming others for the fault. Recovery model, again, super important because it's a therapeutic approach that prioritizes resilience and management of life changes rather than the complete symptoms and elimination. So when we say recovery model, we are not looking at the diagnosis. We're looking on the person, on the individual. So if I'm saying Jake has schizophrenia, I'm not looking at the diagnosis of schizophrenia. I'm looking at Jake. What can Jake do? How can I individualize, do a person centered care specific for Jake? So encourage self guidance and independence, right? So it's a tailored to individuals with focus on the person, not the diagnosis. As you would expect, is a non-linear approach. So you would not expect that the recovery just to take off and have no setbacks. Setbacks are expected. This is a non-linear. Recognize recovery as an ongoing process, inclusive of growth, potential relapse, and experimental learning. So you're learning from doing it, from experiencing victories and failures. So recovery model is non-linear and experimental learning. So learning from doing. Encourage the self-guidance and independence. And there's a model that's person-centered of care. Four things that are super important. So place importance on the understanding what lessons have been learned from the past experience. For instance, the focus isn't on the diagnosis, but on the person's capabilities, interests, and aspirations. So that is the recovery model. checking on learning. You are counseling a 23 years old married Hispanic mother who brought a 4 years old son to the clinic with the symptoms of a mal de ojo, including diarrhea, vomiting, and fever. What is your next uh, action? So here, this is a cultural care, right? You have a Hispanic mother, you have this mal de ojo. So your answer for cultural care, it's always a culturally sensitive answer. We covered this on the previous modules. So option A, you want to identify the step the mother has taken to care for the child and symptoms she has observed. Option B, you want to explain to the mother that the viral infection likely caused these symptoms. Option C, you want to educate the mother about maintaining fluids and electrolyte balance in the in her child body. Or you want to respect the mother's understanding of her child illness. Okay, so this is a very hard question, right? Because you have potentially very good answers there, right? But because this is a cultural question, even though you might be inclined to pick other answers, I hope that answer D was what you pick because you were respecting the mother understanding of her child illness. So basically, here, in other words, I am saying here, hey, if you believe this was Maldeo, which is a evil eye for Hispanic population, then I cannot tell you that this is not evil eyes. This is a viral infection, right? Option A, it's a very good option too, but it's not taking into account the culture and understanding of cultural sensitivity answer. Okay. This question could easily throw off a lot of people on the board under pressure because it's not something that we are accustomed to, and we have to train our brains to give a culturally sensitive answer. Okay. Now, quality improvement. When you hear quality improvement, I want you to think about improve the system, decrease cost, and improve productivity. So these are three important aspects you need to write it down. Quality improvement equals to improve the system, decrease cost, and improve productivity. Okay. So strategics that you use, if you see a quality improvement question, look for a retrospective chart review. If you see a problem and you think it's quality improvement, you want to look for retrospective chart review. So I put in a question a while back about delays in transferring a patient from the ER to the psychiatric unit. So the answer, it was a root cause analysis because it was the problem that was happening and we wanted to fix. But a lot of people put this as a quality improvement. When quality improvement, it falls under the Plan, Do, Study Act, which would have been the second best option. But here, when you're looking for quality improvement, if the STEAM of the question had said about retrospective, the nurse now is doing a retrospective chart review of the delays that was encountered in the ED to find out what is the options, right? Well, what's the cause? Then this is a quality improvement. You do a retrospective chart review. But if the question doesn't give you that, then you start thinking a little bit more broad. Okay. The case here, it was more of a root cause analysis. Now, quality improvement, you do the improve system, decrease cost, and improve productivity. Do retrospective chart review, and then you do the process of quality improvement, which is the PDSA: plan, study, plan, do, study, and act. It's not plan, study, do, act. It's not plan, act, study, do. So why am I saying that? Because I have seen questions in which you would have quality improvement. This is questions out there on the internet in which has quality improvement, and they would have option A: plan, do, act, study. Option C: study, act, plan, do. And then we'll be like, whoa, this is question number 100. And do the orders matter? Yes, they matter a lot. So the first is the plan. Then you do, then you study the act, right? You study the function, then you act. So the orders matter here. So PDSA, okay? Remember PDSA. Do not mix the orders because the order is important. Okay, what are the four components of health policy, right? So in health policy, we have a process, and the process consists of the formulation, implementation, and evaluation. So the four components is the process, the policy reform, policy, environment, and policy making. So what is the process? The process is the formulation, implementation, and evaluation. You can use the acronym FEE. The policy reform is changing the programs and practice. That's the policy reform. How about the policy environment? Where does it take place? Is it in the government? Is it in the media? Is it in a school? Or is it in a hospital? And the policymakers, who are those? These are the key players and stakeholders. In order to do a change in health policy, the first action in order to do a change in the health policy is to assess the organization barriers and facilitators. Second action, the order is important, is to brainstorm with the stakeholders. So you assess the organization's barriers and facilitator. Then you go to the brainstorm the stakeholder, talk to the stakeholders. Okay, so assess the barriers and facilitate it to evidence-based principles. The PMHNP assess the knowledge, belief, and practice among health providers through a survey. So how do you assess the organization barriers and facilitators? You can do this through a survey. So lots of questions can come from this slide. So pay attention here. So assess the organization barriers and facilitators first, and you do this by doing a survey. Then you can talk to the stakeholders, right? So policy questions that often says something about collecting funds or filing for funds usually are incorrect answers, okay? It may sound good because fundings are desperately needed in order to move a policy, but the first thing is to assess the organization barriers and facilitate it, and you do this by starting a survey. All right, so case management. Let's talk about case management. It's a type of care delivery that consider the patient and the provider satisfaction as well as the cost considerations to help manage the overall health. Case management can enhance the client's self-care, diminish the fragmentation of care, improve the quality of care throughout the continuum, and boost the client and staff satisfaction while promoting cost-effective use of resources as a valued member of a multidisciplinary healthcare team. For example, if you work in a hospital and you are tasked to creating a module based on multidisciplinary team approach to enhance the patient quality of care, your actions to develop a model inspired by the case management model. Okay, so if you are tasked to develop a multidisciplinary team approach, you want to do a case management model. Okay, super important. Now, laws cases in psychiatry, right? We cover habeas corpus, which is ensure the protection against unlawful and indefinite incarceration. So basically, here the patient can ask for abscorption and leave against medical advice. The Taroff principle, also known as duty to warn, so it mandates a duty to warn a potential victim of imminent dangers from homicidal client. Actions may involve the state board of nursing policies, right? So calling the state nursing board is a possible answer, or you may call the police as well. Rain versus claim, Rainy versus claim cases. So affirms that involuntary commitment committed patient, unless found incompetent or in an emergency, has a qualified right to refuse psychotropic medication. So Rainey versus Claim has the right to refuse medication, right? Unless they are found incompetent or in an emergency situation. Okay. Donald Donaldson versus O'Connor, the O'Connor case, very famous. It's a guy that was in prison. I mean, not in prison. He was in a hospital for 15 years, right? And he was not allowed to leave. And then they went to the courts of justice, which was known as the Donald versus O'Connor case. So this case is a unlawfulness of prolonged involuntary commitment of an individual who is not in an imminent danger to themselves or others. So remember, O'Connor was not in prison, much like prison, right? He was an inpatient unit for 15 years when he could have been free. He was no risk for himself or others, yet he was in an inpatient unit for a long time. Now, what is the anti-kickback statute, or better known as the Stark Law? Think about the Stark Law as uh, um, picking up money under the table. Let's put it this way: it's a set of law in the healthcare industry that's designated to prevent any illegal kickback or giving money or bribes in exchange for a referral or recommendation for a service. Okay, equipment or supplies reimbursed by the federal health care program. Okay, so here really is a violation of an anti-kickback statute can result in a criminal and civil penalties, include fines, imprisonment, and exclusions from federal healthcare programs. So here, with this law, often comes a case of a pharmaceutical company trying to pay for. We discussed this in the previous module. So, pharmaceutical company trying to I'll pay for your education if you prescribe my medication. So that's against. This is the historic law, and this is a no. Okay. Okay. PHA, there are other levels there, but I'm going to talk about specifically two, which is the pre-operation, right? So in the pre-operation is age 2 to 7. In this stage, you would expect magical thinking, right? Unless if it's an autism disorder that they don't have the magical thinking. So in the pre-operation of 2 to 7, you would expect magical thinking, which is normal. So what is magical thinking? So magical thinking is if I think that my sister has is gonna come out of the room in a red dress, and she does by coincidence, I attribute this to my magical thinking. Okay, so magical thinking is normal and is part of the pre-operational stage, 2 to 7 years old. That's the strategy here. When you're talking about PAG, right, all answer choices may look very similar. If you find something that's odd or in general, let's say three answer choices are to prescribe a stimulant and one answer choice is not a stimulant, so look for that one. Another example is we talked about the fair door, the phallic stage, where masturbating is or touching them, the kid touching herself or himself, being normal or expected, but it's kind of odd. So you might pick that option. Okay. So another stage is the form operation, which is 12 years old and older. So think of this as someone being able to do a science project that needs abstract thinking, right? It's not concrete anymore. It's like able to see the logic beyond what you see in front of the person, seeing the second, third order of effect. Anytime you have a project, science project or hypothesis, think of the formal operation, which is the last stage up to 12 years old and adulthood. Erickson stage, I'm only covering two of them, but one that's very high yield here is industry versus inferiority. Think of this one as age of 6 to 12, right? And here, the ability to learn how things work and understand and organize provide a sense of competency and achievement, right? Friends are super important, uh, play role in how children progress through the industry. If they are able to have friends, they are able to connect, they feel empowered, they feel capable. If they are able to do their homework, get good grades, so they develop a sense of industry. Versus if they are not, to feel inferiority and develop a sense of unable to achieve competency and pride in their ability, right? So that's unfavorable outcome, a sense of inferiority at understanding and organization. Now, another Erickson stage that you may see a lot is the last stage. And Erickson stage is always important to use age. Age is always important because that's very static, right? If someone says the child is age 12, then you know this is industrial versus inferiority. If the child is 1 years old, then you know that's the first stage, right? If the child, it's whatever stage, so you must know that the age here is important. And then a good example of this is integrity versus despair. So this is the last stage. So if you get a case in which the patient is 70 years old, 70, you know this is part of integrity versus despair, because 65 years old, here we look at the life. They look at the life and say, hey, did I do all things that are needed to do in this life? Did my children grow up to be good human beings? Did I achieve my goal and aspirations? And if they do, they feel a sense of integrity. If they don't, they may feel a sense of despair, like missing out in life, something that they didn't accomplish or didn't do well. So let's do a check on learning. And I think I have talked about this example in extent, but I want to go over one more time because this is the last review, guys. So let's say, for example, you have a patient with the HAM-D and his initial score is 22. You prescribe antidepressant X, and 4 weeks later, the patient comes back and says, "Hey, man, I feel much better." And you did the HAM-D, and the score is 16. What is your action? Increase the medication, decrease the medication, switch the medication, or keep it the same? So the key here, regardless of what the score is, whether it's increase or decrease, the key here is to keep the medication the same because it's 4 weeks later, right? So the medication needs 8 weeks, 6 to 8 weeks. 4 weeks, you'd see if you're having some benefit, but it's not enough to change the medication, right? Despite of a decrease in score. Now, another one. Let's say you got Lexapro, 20 milligrams, and patient comes back, and the score now is initially it was 22. Well, let's say initially it was 16 for the GAD, and now it comes back at 2, right? So, and there's only 4 weeks. Again, your action is to do nothing. You remain with the medication at the same rate, and you wait 8 weeks before you make a change, okay? Especially here, somebody here is stable, very stable. Would you change the medication? No, no, no. Okay? Checking on learning. During a regular follow up appointment with a PMHNP, a patient responds to the PMHNP that her husband is currently at work and told her that he wants to commit suicide. Okay. The PMHNP initial action is to notify the husband's supervisor, notify the husband's family, ask the patient to check on her husband, or contact the police and notify them of the husband suicidal threats and location. So again, I think by now this is pretty simple. I hope you would pick D, especially if you didn't even know you you are passing the buck here. You passing the responsibility for A, notify the husband supervisor. It's not his job. B, notify the husband family. It's not the family's job per se, right? And asking the patient to check on her husband, you always giving you referring that responsibility to others, right? But always it's a correct answer to inform the police, because in this case they are the authority that would take care of the problem with the most direct route. Checking and learning, which of the following patient is the highest risk for suicide? This one I repeated many times because it's important. It can get confusing, especially if you didn't take this class. So here we got a patient a 30 years old married African American female with a previous suicide attempt. B, a 35 years old single Asian with uh, with a previous suicide attempt. Let's say age a female. Okay. 38 years old, single African male who is a manager at the bank. And D, you have a 68 years old single Caucasian male with depression. Which answer choice would you pick here? Well, if you picked anything but D, that would be incorrect. D is the correct answer, although it doesn't seem very strong, does it? It doesn't have a previous suicide attempt. But the key here, the hallmark here, is you pick the answer choice that has the most risk factor. So let's look at D. 60 years old, that's one. Single, that's two. Caucasian, that's three. Male, that's four. And five is depression. Let's count a 30 years old married African American female with a previous suicide attempt. So here we only have one risk factor. All right. Now B, 35 years old, single, that's one. With previous suicide attempt, that's two, right? So although you need the race here to really consider the age, but the I didn't put a gender there. So C, you have a 38 years old single African male who is a manager at the bank. So you got a single and you have a manager of the bank at stressful situations and so forth. So clearly D is the stronger answer. And why? Because you count the risk factors and you pick the one that has the strongest risk factors. Now, if the question asks you, which of the following risk factors alone is the highest indication for highest risk for suicide, right? One that has previously had a suicide attempt would be the answer. If the question asks you which of the following psychiatric conditions, right, has the highest risk for suicidality, then in that case, I hope you picked schizophrenia. If it's the diagnosis, which of the following diagnoses has the highest risk for suicidality? Schizophrenia would be the one. Which of the following risk factor alone has the highest risk for suicidality? Then there would be a previous suicide attempt. Now, when you have comparing patients A, B, C, or D, you have to calculate the risk factors and pick the one that has the most risk factors. Okay. All right. Another check on learning here. A 72 years old female is brought by her husband with the following symptoms for 2 months, right? Increased forgetfulness, decreased activities, decreased appetite, and the patient has a history of hypertension and is currently being treated with lisinopril. So, the examination reveals no abnormalities, and the mini-mental static exam score is 24. During the assessment, the patient declines to answer some questions and need to be urged to participate. The most likely diagnosis is, well, several cues here, right? So the patient refused to participate, basically saying, I don't know. The mini mental static exam is a slightly possible dimension, right? What we know from 0 to 30, 25 to 30, higher numbers are better. So it's just below normal, so semi-normal. Then you have distraction here is lisinopril, kind of trying to throw you at vascular dimension, right? And but the biggest key here for this question is 2 months. You know that 2 months is not long enough for a dimension case, a true dimension case. So this got to be option C, depression. Okay, or major depressive disorder. Okay, guys, so this was it. This was more of a fun. Make sure you know all the examples. I think if you put together all the examples here, right, you could easily create 200, 300 questions. These are the most high yield content you need to memorize, understand, and as you walk into the test center, make sure that you already counted the victory, that you have done well, you started, and make sure that you put your questions on our WhatsApp group so I can get to them or other students can help out. And it was a pleasure to have you with us during this course. My name is Dr. Lopez, and I wish you the absolutely most success. Should you need anything, please don't hesitate to ask. See you later. Bye bye.